Hello, myself Dr. Kiran Kumari. I am Assistant Professor in Physiotherapy Department, IIMT University, Meerut. Today we will discuss about carpal tunnel syndrome. So, carpal tunnel syndrome can hinder your ability to perform in your work and personal life. Understanding how this condition affects the wrist is important for prevention and decreasing progression. So, 50% of carpal tunnel syndrome cases are caused by work and could be prevented according to the study supported by Center for Disease Control. So, let us know the anatomy of carpal tunnel. The word carpus is derived from a Greek word karpos, which means wrist. The wrist is surrounded by a band of fibrous tissue which normally functions as a support for the joint. The tight space between this fibrous band and the wrist bone is called the carpal tunnel. The median nerve passes through the carpal tunnel to receive sensation from the thumb, index, middle finger of the hand. Here you can see the diagram. This is the carpal bones, these are the tendon sheath, muscle tendon sheath, and this one yellow part is the median nerve. Here also in the diagram, this is the transverse carpal ligament and this yellow structure is the median nerve. This is known as the tunnel through which median nerve is passing. So, carpal tunnel syndrome is also called median nerve compression. It is most common focal peripheral neuropathy, results from compression of the median nerve at the wrist. Now, epidemiology. CTS is common disorder. Estimated prevalence is in general population is 1 to 5%. Usually occurs between the ages 36 and 60 years and is more frequent in females. Female into male ratio is 3:1. So, females are more prone for carpal tunnel syndrome. So, what are the risk factors? Obesity, female sex, coexisting conditions like diabetes, pregnancy, rheumatoid arthritis, hyperthyroidism, connective tissue disease, pre-existing median mononeuropathy. These are the risk factors, genetic predispositions. Now, median nerve motor innervation and sensory innervation. Motor, there are two types of nerves, sensory nerves and motor nerves. Motor nerves sends impulse to the muscle for movement and activity, action, and sensory nerves sends impulse to the brain for sensation like touch, heat, feel, whatever you feel, sensation, that is sensory nerve. So, motor innervation is first and second lumbricals, muscles of thinner eminence, opponens pollicis brevis and flexor pollicis brevis. Sensory innervation, skin of the palmar side of the thumb, index and middle finger, half the ring finger and nail bed of these fingers. So, this blue area is showing the sensory innervation. This green is supplied by ulnar nerve, this pink area is supplied by median nerve and this blue area is supplied by radial nerve. So, here median nerve is affected. So, this pink area will be affected. Sign and symptoms. What are the sign and symptoms? What will patient feel? So, tingling sensation will be there, numbness or discomfort in lateral 2.5 fingers, intermittent pain in the distribution of median nerve. Symptoms gets aggravated at night. To relieve the symptoms, patient often flicks, that is shaking of wrist, like shaking a thermometer like this. So flicking sensation, flicking activity will be there. Now what are the motor changes if there is carpal tunnel syndrome? So what are the motor changes? Ape-like thumb deformity, loss of opposition of thumb, index and middle finger lag between index and middle finger lag behind when making a fist. What are the sensory changes? Loss of sensation of lateral 3.5 digits, including the nail bed and the distal phalanx on dorsum of hand. So the sensory innervation will be not present. So an important point to remember for carpal tunnel syndrome is that there is no sensory loss over the thinner eminence in carpal tunnel syndrome, because the branch of median nerve that innervates it, that is palmar-cutaneous branch, passes superficial to the carpal tunnel and not through it. So it is passing superficial. So it is not passing through carpal tunnel. That's why there will be no sensory loss over the thinner eminence. Here in the diagram you can see finger lag while making fist. Fist will not, patient will not be able to make fist, there will be finger lag. This is ape-like deformity. There will be atrophy. There will be atrophy on the thinner vasting. On the palm, on the thinner surface, there will be atrophy. So what are the vasomotor changes? Skin area with sensory loss is warmer. Skin will be dry. Now trophic changes. Long standing cases leads to dry and scaly skin. Nail cracks easily. Atrophy of the pulp of the fingers. So pulp of the fingers, here the muscles will also get atrophy. Now diagnosis. Diagnosis, first we will take the history, how it occurs, any medical history or surgical history, all the history we will take. Then physical examination. In physical examination we will see less sensitivity to pain where the median nerve runs to the finger. Okay. So there will be less sensitivity where the median nerve supply our hand. Thumb weakness, inability to tell the difference between 1 and 2 sharp points on the finger tips. So patient will not be able to differentiate between the 1 or 2 sharp points. There will be flick signal. So when we ask patient what do you do when your symptoms are worse, then patient will response with the motion that resembles shaking of a thermometer. So this from this signal we can suggest that a patient may have carpal tunnel syndrome. Now there are some tests through which we can special test through which we can diagnose carpal tunnel syndrome. First one is PHALEN'S test. The patient rests the elbow on a table, the wrist flexion with fingers pointing downward and the back of the hands pressed together. Here in the diagram you can see like this, and we will say patient to press. If symptoms develop within a minute, then it indicates that CTS is positive or the patient is having carpal tunnel syndrome. Here in the diagram you can see. Next is TINEL'S sign test. In the TINEL'S sign test, the doctor taps over the median nerve to produce a tingling or mild shock sensation. Here you can see the point where the doctor will tap. Okay. So there will be tingling or mild shock sensation. If tingling or mild shock sensation is present, then it indicates that patient is having CTS. Next is hand elevation test. In this, the patient raises his or her hand overhead for 2 minutes to produce symptoms of CTS. Okay. Here you can see patient is asked to elevate his hand overhead for 2 minutes, and if the patient is having CTS, then symptoms will occur, that is tingling or numbness like this. Then Dukan's test. The doctor press over the carpal tunnel for 30 seconds to produce tingling or shock in the median nerve. So, here you can see the point where the doctor will press for 30 seconds and this will produce tingling sensation. So, this indicates that the patient is having CTS. So, these are the special tests which we do. Here you can see PHALEN'S test, hand elevation test, Frick sign, TINEL'S test, square wrist sign. These are the tests and signs which indicates patient having carpal tunnel syndrome. Next, diagnostic test. So, there are diagnostic tests through which we can diagnose patient having CTS, that is nerve conduction studies. To perform nerve conduction studies, surface electrode are first fastened to the hand and the wrist. Small electric shock are then applied to the nerves in the fingers, wrist and forearms to measure how fast a signal travels through the nerves that control movement and sensation. So, in nerve conduction test, this is the machine through which electrodes are placed, and through this machine we can see the nerve conduction velocity. Next is electromyography. To perform electromyography, a thin sterile wire electrode is inserted briefly into a muscle and the electrical activity is displayed on a viewing screen. Electromyography can be painful and is less accurate than nerve conduction. So, here in the figure you can see a small sterile wire, thin sterile wire electrode is inserted, and in the screen it is visible. We can see the nerve conduction velocity and all. So, this is electromyography. Next is management. The goal of the treatment for CTS is to reduce the swelling and pressure on the median nerve. So, basically this condition is occurring due to compression of median nerve. So, what will be the goal? That the pressure or swelling on the median nerve, which is compressing the median nerve, swelling or any pressure should be reduced. Wrist brace. Avoid inadequate posture and repetitive wrist movement. So, repetitive wrist movements in many workplaces also, like in office where people are working on computers and all, it also affects median nerve, which leads to CTS. So, repetitive wrist movement and workplace factors may also cause CTS. Essential tips to prevent carpal tunnel syndrome at work. 18% of workers who develop CTS leave their job in 18 months. So, to prevent this, so carpal tunnel is caused due to fatigue and repetitive movement on the mouse for the people who are working in the office on computer. So, we can teach them the ergonomic methods how to prevent this. So, office workers have 2 by 3 office workers have experienced pain in the last 6 months due to incorrect posture and office ergonomics. So we can teach them the ergonomics, that is, take break every 25 minutes from the computer, keep your shoulder and back relaxed, do not slouch, sit with your computer screen at eye level and knees slightly lower than your hip joints. If you use a keyboard, keep it at elbow height or slightly lower. So these are the ergonomics which we teach, so that not only carpal tunnel syndrome, other problems also like back pain and all, these all will also be prevented. Now non-surgical treatment, analgesic like NSAIDs, corticosteroids and orally administered diuretics can decrease swelling. So these are the medications. Local cortisone injections is also given. Corticosteroid and lidocaine can be injected directly into the wrist to relieve the pressure. Splitting is generally recommended after local corticosteroid injection. If the first injection is successful, a repeat injection can be considered for a few months. Surgery should be considered if a patient needs more than 2 injections. Now, what are the surgical methods? Generally recommended if symptoms last for 6 months. 2 types of CTS release surgery, open release surgery and endoscopic surgery. These are the 2 surgeries performed. Here you can see open release surgery. And endoscopic release for carpal tunnel syndrome. Now rehabilitation after surgery. Gentle massage for the scar tissue desensitize the incision. So after surgery we can give gentle massage on the scar tissues. Modalities to decrease pain, inflammation and swelling like heat and cold. Progressive exercises to strengthen and stabilize the muscle and joints in the hand, and exercises to improve fine motor control and dexterity. Now we come to physiotherapy management. With early stage CTS, conservative care is recommended as a first step. Physiotherapy treatment can be effective to reduce your symptoms and help you get back to your everyday activities. Depending on the causes of your CTS, your physiotherapy program may include patient education. So in patient education, we will teach them how to the ergonomics which we have discussed earlier. Your physiotherapist will teach you ways to improve your condition and keep it from getting worse. This may include education on the importance of changing wrist positions, such as avoiding bent wrist position for long period, proper neck and upper back posture, avoiding forward head posture or slouching. Then stretch breaks during your work or daily routine. So these are the ergonomics which we have discussed earlier also. Now stretching exercise. Here you can see in the diagram also. Wrist bend upward position. Keep the elbow straight and palm facing down. Here. Instruction: bend wrist up. Use the opposite hand to press the stretching hand back towards the body. Hold 15 to 30 seconds and 3 sets for 10 repetition. Wrist bend downward. Here you can see wrist bend downward position. Position will be keep the elbow straight and palm facing down. Instruction will be bend wrist down. Use the opposite hand to press and stretch the hand back towards the body. Hold for 15 to 30 seconds. Again 3 sets for 10 repetitions. Then strengthening exercise. Forearm muscles position, support the elbow and place affected palm on the table. Place another hand across the affected knuckles at 900 and push down. Here you can see instruction: push affected hand upward, hold for 5 seconds and do 3 repetitions for 3 sets for 10 repetitions. Now strengthening exercise. Position: support the elbow and held fingers out straight. Instructions: squeeze the rubber ball, hold 5 seconds, do gently 10 repetitions, 3 sets. Now mobility exercise. Position: support the elbow, arm pointing up and wrist straight. Instruction: bend wrist forward, hold 5 seconds, straighten wrist, then bend backward, hold 5 seconds, do gently 10 repetitions, 3 sets. So here you can see active range of motions, wrist stretches exercises, tendon glides, wrist flexion exercises, wrist extension exercises and grip strengthening. These all are the exercises we can recommend. Now cold and heat treatment. Your physiotherapist may use cold or heat treatment or recommend you to use ice or heat to relieve pain. Physiotherapy modalities like TENS, ultrasound have little useful effect on hand sensory discomfort. Now splinting. So physiotherapist may recommend that use splint at night, because at night the discomfort is more. So at night you can use splint. Here in the diagram you can see the splint. Thank you.